All right, do you have a elbow? Oh, there is. Oh, okay. Jason, you put your knee on just because the dim one is.
Oh yeah.
You do I.
需要剪个头发。
All right, so James, you're going to be communicating on a pain scale of 1 to 5 in order to communicate how much pressure I'm using. Would you like me to review the pain scale for you?
Thank you.
So firstly, I like to do a little bit of a courtesy drape just to make sure you're nice secured here in the top. Perfect. And just put your hands on your shoulders. Either or. Just on the perfect. All right, so of course, I'm going to start with a little bit of treatment in the upper portion, back, neck, and shoulders a little bit, right? Nice breath in and out. Nice big breath. You need treatment. Okay, so let's say I've spent like a decent amount of time working the upper back and shoulders, into the neck a little bit, working into the shoulder girdle a little bit, and just getting these structures to let go of it. Kind of needs it, so.
The pain and stretch.
We will be going more into how to perform a nice shoulder treatment in upper spinal as well too, so don't you worry. Nice breath in. Excellent, good job. Okay, so once we got to a point where it feels like this entire shoulder girdle is nice and released, we're gonna start going in and addressing specific areas. So it would be nice to address the SCM and into the scalenes, of course. Those ones you can go ahead and address however is comfortable for you. Gentle C-bowing is what I would end up suggesting. So it's what we were dealing with torticollis, basically, right? But instead of targeting just the SCM, we can use those same GTO release with the scalenes as well too. So I'm not gonna spend a whole lot of time demonstrating that one. Now for subclavius, where is the attachments for subclavius? The medial 1/3 of the inferior aspect of the clavicle. All right, so that's actually real close to midline. You'll actually feel when you're on subclavius and when you drop off of subclavius because it no longer will be firm. Now the thing is, I see a lot of people performing subclavius release just like this, where they landmark on the muscle and they just boop. 5, 4, 3, 2, 1, take a nice breath in and out. Technically, that's not wrong. But there is a way to be a little bit more effective in being able to target subclavius, and that is creating space for that muscle. So try this with your partner when you have them on the table. Start landmark on subclavius without bringing their arm into abduction. Try bringing their arm over into abduction, and all of a sudden you have space to be able to actually bow that subclavius. All right, nice breath in. So it's just pressure release with deep breathing and encouraging that subclavius to let go. It's literally just a pressure release. Let your chest drop, let it drop, drop. Is your hand up for a question or? Okay, I'm just checking you. Keep going. I just wanted to make sure it wasn't a question, that's all. Okay, so in order to effectively get to the full span of subclavius, highly suggest you take an element of shoulder abduction to it as well too, because again, it will open up some space for you to be able to actually bow into subclavius, okay? Nice and easy. The one thing we're gonna be looking for that one is not only just positioning, but if you're landmarking properly, which means that during an OP, James and I might actually come by and actually feel if you're on subclavius or not. The biggest mistake I see with this one is people are too far lateral when trying to do the subclavius release. Okay? Comments or questions about that one? Very straightforward, right? Yeah. All right, now pec minor is a little bit harder for people to landmark, and I have a feeling James is going to be super tight and restricted in the chest because it looks like he works out a lot. So I'm gonna do my best to get that pec minor. Okay, so as we know, pec minor is in a sensitive area, as well as there's a lot of firm muscles over top of it. So James, this is one of the techniques that will require me to work into sort of the front of your chest area and into the side here. It can be quite uncomfortable because of where the muscle is. So please let me know if you need me to stop or change anything I'm doing. Are you okay with us still working in the chest area?
Yep.
Perfect, thank you. If you are concerned about just land marking and you would like to be extra careful, you can ask your patient to border off for you. So James, just because I am going to be along the side of the chest here, can I get you to use this hand here to cover the front of your chest? Perfect, and then I will just be sure to stay away from your hand area. The front of this side of your chest. Be specific, y'all. And then if we would like to help him support his arm up so he doesn't have to hold it up. There you go. Now he can relax a little bit. All right, so then that way we can work along the side of the chest there without any worries because he's got himself nice and secure. Okay? So one thing I see that makes it harder to be able to landmark on pec minor is a lot of students try to have the arm out here and then go into pec minor. What is that doing? It's tightening everything by pulling it taut, right? So we actually want to start sinking in with a little bit of slack in that area, okay? So the goal is enter through the lateral aspect of the axilla, and your goal is to draw literally a straight line towards his chin. So when you go in underneath pec major, you draw a straight line up towards his chin when his head is in neutral. You go as far as you can, and when you land, so just fingertips down onto the ribs, you should be on pec minor. How do I confirm? Protract his shoulder gently. I'll get you to protract your shoulder for me and back off. Not quite on it. And try there. There it is. Good. And relax. So we can actually do combination of contract, relax, and pressure release. So nice breath in, James. And out. Sink a little bit. Drop it. Drop it. Keep going. Keep going. Good. And nice and gentle. I'll get you to protract forward. Hold for 5, 4, 3, 2, 1, let go. Where are we at on the pain scale, James?
2.5.
2.5? Good. All right, nice breath in. And I'm gonna try to sink further. Good. Good, I'll get you to protract a little bit. Perfect, and let go. Good. And then am I just gonna pull my hand right out of here? No. I'm gonna go nice and gentle, preferably with breathing. Nice breath in. And slowly coming out of that pec area, and then I'm sorry, because it's not a fun technique. So in the area we do some soft tissue work, general stuff afterward, principles of massage, right? All right, so once we've gone and released all of our key components, we've gone and addressed our scalenes, we've gone and released our subclavius, we've gone in and addressed our pec minor. So technically all the soft tissue and muscular structures that are in our way, we've addressed them a little bit, right? One more thing we can do to increase space is our clavicular mobilization, okay? One thing that you will get acquainted with in my upper spinal class is before we do any mobilization to any of the joints, we must assess the joint. That's why we gotta be careful with rolly chairs. We must assess that joint. So I'm not just gonna be like, okay, I'm gonna mobilize your clavicle, right? I'm gonna assess to see the quality of the movement of his clavicle. So if you were to get clavicular mobilization on your OP, what's the first thing you're gonna do? You're gonna assess the clavicle so you know which one to apply it to. After you're done your mobilization, do you have to assess again? You better. All right, James, so now we're gonna be moving on to another relatively uncomfortable technique. This is gonna be a clavicular mobilization. I'm seeing I probably have to do it to this side. So for this mobilization, it will require me to place my hands again on the top portion of your chest area and grasp onto a bone that is in this upper portion of your chest. So it can be uncomfortable because of where it is as well as the type of technique we're going to do. Purpose of this technique is we're just going to try and create more space for the nerve passing through in that area. But there is a chance we'll probably cause a little bit of discomfort with this technique because it's a little bit intense. So if you feel like it's too much or if you need me to stop what I'm doing, you just let me know. Okay? Do you have any questions about what it is that we're trying to do? Oh yeah, but we would like to hopefully try and decrease your symptoms related to TOS. Positives and negatives, right? Do you have any questions? Do you have any questions for me? Okay. All right, so first things first, the way we are assessing the clavicle is using breathing, okay? When your patient breathes, the clavicle should roll up and backwards when they breathe in, and when they breathe out, it should roll forwards and downwards, okay? So you can use your thumbs, you can use your hands, whatever is most comfortable for you to assess that motion. So James, I'll get you to take a nice slow, full, big breath in and out. And it's actually, this one was slower to ascend, probably because I haven't worked on the subclavius. So I'm going to do little subclavius release, and then I will demonstrate that mobilization, and then I will show you an alternative mobilization to the clavicle as well. And again, big breath. And out. Keep dropping, keep dropping. Excellent. Good job. That was nice and quick. That's better. And down. Okay, so it is this side I'm going to go ahead and correct. So with this clavicular mobilization, the idea is you're trying to encourage the motion that doesn't want to happen. Okay? Mostly because it's going to be stuck downwards. So in order to create space in this subclavius space, am I going to be trying to encourage it to roll up and backwards or roll down and forwards?
Up and backwards.
Up and backwards, which means we're going to use his in-breath to perform the mobilization, and when he breathes out, we are going to resist the rolling down and forward. Okay? So I'm going to hook into the clavicle. Right? I like to just stabilize my neck. James, take a nice big breath in. When he breathes in, I'm literally pulling that clavicle up, and go ahead and breathe out. When he breathes out, I'm pinning it up. Good, and James again, big breath. And out. Good. Where was that on the pain scale?
Like a 3.
It was a 3 to 4, and it actually feels like it has moved. Go ahead, nice breath in. Way better. Beautiful. Yay, we mobilized it. Am I in trouble?
I saw you in the hallway. I had to
Hi, how you doing?
and say hello.
Oh. Okay, so I'm not in trouble. Okay.
No, not yet.
Oh, not yet. Great. Oh, believe me, I will. All right, so that is the primary mobilization that we're going to utilize with breathing. Okay? There is another type of mobilization for the clavicle that I actually use sometimes, and it's for individuals who actually have a depressed, interiorly displaced clavicle. So sometimes people might have that medial attachment actually deeper than the other side, or even the lateral aspect as well too. So depending on which side you're trying to target will determine what you're focusing on. If you're focusing on the more medial attachment, then that's where your force will be. If you're focusing more on the lateral attachment, that is where your force will be. Okay? Now, something to keep in mind with this mobilization. That mobilization that we just did, he said was about a 3 or a 4. This one is going to be significantly more uncomfortable than that. I'm sorry. I'm sorry. All right, James, so same consent, except this one's probably going to be more uncomfortable. Is that okay with you? Good, go ahead and flag me down, tell me to stop if you need me to stop anything I'm doing. Okay? Awesome. So the goal with this one, again, we are going to assess to see which clavicle is more depressed inwards, and it feels like it's this one here because we didn't spend as much time releasing the structures surrounding it. So what we're gonna do is you are going to landmark on the side that you are trying to mobilize. So for him, it's gonna be more medial. So from here, you're gonna hook into the clavicle. Not comfy. Are we okay? Good. And all you're gonna do is you're gonna take your patient's arm and draw it anteriorly, and you should be able to get underneath that clavicle, hook under it, pull anteriorly, hold it forward, and drop the arm to encourage a mobilization backwards. You okay?
Yeah.
Would you say that one was worse?
Yeah.
Yeah, it literally feels like somebody's trying to rip your clavicle out of your chest. So use this one with caution. Okay, so that one is just super effective to utilize in treatment. The one that we are expecting to see for the purposes of your OP and for TOS is that rolling and gliding one. Okay, So don't feel that you have to torture your partner, but you're allowed to if you have their consent. Okay? Okay. Thank you, James.
Thank you.
All right, and then we can go ahead and reassess, and that is definitely a lot more anterior than the other one. Great job. Okay. Do you want to have getting off the table?
I'm good, thank
Okay,
you.
wonderful. All right, so we are going to get you guys to spend about 15 minutes